how to code medical claims in a way where you get paid faster and get paid more.
It's only when an employer realizes and the light bulb goes off that they say to themselves, well, this is one of our biggest P&L expenses.
You can piece together your plan the way you see fit, as long as, of course, it follows rules and regulations as set by ERISA. Use a pharmacy benefit manager that's not one of what you and I would call the big three. Optum, Express Scripts, and CVS that still own about 80% of the market. The same thing on that pharmacy side is what we were talking about on the medical side. PBMs make more money when you spend more.
Are you sick and tired of the high costs and inefficiency plaguing our U.S. healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live. Ladies and gentlemen, my name is Ray Kober. Welcome to Broken Healthcare. And I am honored to be joined today by our next guest, Scott Fuqua of AMPS. Scott is a wealth of knowledge in our space, and for anyone that's interested in figuring out, can I do better on healthcare than the status quo? Is there something beyond my insurance carrier that I could do to lower my costs in the short term and the long term? Scott is an expert, and we are very honored to have you here with us today. Welcome, Scott.
Yeah, thanks, Ray. It's good to see you.
Yeah, same here. So I want to dive into how I always like to kind of open with, how did you get involved in this crazy insurance business to begin with? What was your path? How did you get here?
Yeah, it's an interesting one. Went to University of Illinois in Champaign. I come from Illinois. I'm in Illinois today. Went down there for a business school, business and marketing. Right out of college was a rough time for everybody my age in terms of the market and job opportunities. So I got really lucky and actually moved to London for about 2 years and worked for a small marketing firm over there. It was an outstanding opportunity. That didn't pan out for various reasons. And when I came back, I ended up having a friend connect me with somebody that he knew over at Liberty Mutual. So I started within the workers' comp space. Maybe in about a year and a half, 2 years into that, I thought, boy, that one's not for me. But some individuals, that was not a fun job here in Chicago dealing with workers' comp, especially at the time. But I had another friend that was involved with an organization that is no longer, with all the consolidation in this industry, with a company by the name of Healthcare Compare. In fact, I don't even know if that rings a bell with you. But it was a PPO and bill review, and they did different things. So that's where I started getting involved in healthcare. And then, like what happens with a lot of people, you just kind of start to get wrapped up into where the opportunities are at. I think I stuck around with it because as I learned more and got to do a little bit more of what I call peeking under the hood and figuring out how the sausage is really made in healthcare, I was really blown away, to be honest with you. I've been asked similar questions like this before. Why are you so passionate about healthcare and what you're doing? And that's an interesting question because, again, I kind of fell into it to a certain degree, but I think what drives me is I've never liked the bully. I've never liked the con artist. I've never liked those types of situations or people. And as you start to learn about what's really going on in healthcare on both the medical and pharmacy side, you realize it is quite a bit of a shell game. It is a bully type mentality. And because of that, I just felt I could make a difference here. And so that's why I stuck with it.
Yeah, that resonates with me. I've always found myself, one of my favorite movies, if not my favorite movie of all time, is Rocky. And Rocky it's a love story. People that may not be completely familiar or have seen it but never really seen it. It's an incredible love story. But it really is about the underdog. And that's what resonates with me. It's the idea that against all odds, this, you know, seemingly loser guy from Philly could rise up through the ranks and fight the champion of the world. And so that resonates with me. Do you remember what, kind of your first aha moment was, the first time that that it really dawned on you that this game is rigged and what's going on out there is just, this is ridiculous?
I think the very first time was when I was involved in doing some medical bill review for the first time with Healthcare Compare, and the amount of errors and things that are billed on medical claims. A lot of it, let's be honest, a lot of it is by design. You have revenue cycle management, which what I read recently is that market segment is actually growing by like 18% a year. But as you know, and others may not know, that's a strategy and expertise within the health systems across the country on how to code medical claims in a way where you get paid faster and get paid more. So upcoding and unbundling of codes and all these different kinds of things, I started to realize, wow, this is a mess. But then what really hooked me was when I found out, yeah, but if you're a self-funded employer and you're accessing that vendor, that PPO network, who is using those facilities within their network to bill with all those errors, you don't have the right to audit those claims if you're going to be using the PPO. So I thought, boy, what's really going on here? Who's really the client? And
Yeah.
that's what really started to wake me up. And then it just went from there. As you know, as you continue to peek under the hood, it's really a bunch of misaligned incentives, and you realize this industry benefits when people pay more money, not less money, which is the complete opposite of what everybody's looking for.
Yeah, and I think that goes back to even before the Affordable Care Act was introduced with the MLR, the medical loss ratio baked
Yep.
in. I think the perception is that insurance carriers, well, why would they want to bill more? Why would they want to take on more claims? Because I think the perception is that somehow if they do a better job managing claims and keeping claims low, that they capture the delta between the insurance premiums that they charge and the premiums that they pay out. But that's not at all the way it works, is it,
Right.
Scott?
No, it's not. It's not. Based specifically about the MLR, you have this essentially set for insurance carriers a specific margin, a 15 to 20% margin. So for a for-profit organization, that has a lot of shareholders, that's not what they like to hear. So the idea is, if my piece of pie is only so big, how do I make that piece of pie bigger? I got to make the whole pie bigger. So if you spend $100 this year, I put $15 in my pocket. So do I want you to spend 50 or do I want you to spend 200 next year? I want you to spend the 200. And the same thing happens on the pharmacy side. Traditional PBMs make money. Well, they make money lots of ways, but one of the ways they make money is selling drugs, owning inventory, things of that nature, which again, on the pharmacy side is the complete opposite of what self-funded employers are wanting to do, is find a way to control those costs. So you mix those two things together, you have all the true payers, the employers, the ones taking all the risk, whether you're self-funded or not, you're paying the freight, whether it's premium or claims. Either way, it's all your dime and all your risk. To find out that for an employer, it's hard to get them to understand that everybody that they've been working with, potentially everybody, including a lot of times their broker, as you know, is not doing what they expect them to do or want or need for them to do. So just one of a million examples that you and I know that really is a tough thing to get employers to understand and educate them on. Once you do, it's hard not to see it, but it's a challenge.
Yeah, and I think that's the hard part. It's even though healthcare, well, at least until recently, wasn't in the same league as your 401k management, right? So
Right.
now with the new CAA and transparency laws, the idea is that employers are responsible. They have a fiduciary obligation to their employees to manage plan assets and funds to the benefit of their organization and their employees. And once upon a time, that rule was applied and enforced, and it all falls under ERISA, that, there were guidelines and mandates and rules in place in the finance sector. So, when it came to managing retirement plans, employers are pretty well aware that it's not, it's not optional. They have an obligation to manage plan assets on behalf of their employees, because we're playing with their future, with their retirement money, with their finances down the road. Now with the CAA, we have pretty much those same rules that now apply to healthcare, although it doesn't seem to really have the same teeth, or at least until this point, it doesn't seem like it's really captured the attention of employers. And knowing what you know, because I know this is an area of expertise for you, what do you think is going on there? Why doesn't it seem to have the same weight that it does in the finance world?
Healthcare lobby. It's the healthcare lobby, right? This is why illogical things never seem to go anywhere in healthcare. Why, it appears that consolidation and what I would term monopolies in a lot of markets in this country don't get a look from the government when it comes to healthcare. So I think that's a big problem. It's the follow the money type of situation, I think.
Yeah.
Now, some things are changing, hopefully. But to your point, the regulations are very clear. But kind of like the transparency rules and from price transparency that went into place a handful of years ago, we still have a very large percentage of healthcare or health systems in this country that aren't abiding by the transparency rules. And you have just about every large carrier that I've bumped into that is pushing back very hard on the CAA regulations as well, and saying that they're interpreting them differently than, let's say, the employer and broker community and folks like myself. I don't know how you misinterpret it. I think it's pretty clear, but I think that's the challenge. I have heard that it's gone through committee. It has not been voted on or adjusted or added to the CAA regulations today. But if you can get some financial penalties in place for, TPAs and carriers who refuse to provide self-funded employers with their financial claims data, as the CAA says, I think that's going to finally make the turn to where it's going to make it easier for advisors, for their clients and on behalf of their clients and with their clients to get the data that's rightfully theirs. The $1 million question is, and the big red flag is, if you're one of these major carriers and you claim that, you're still the best solution out there, and why are you hiding your data? Why do you not want to show the world that you're the best?
I could give you 5 trillion reasons why.
Exactly. For you and I, it's very
right.
It's very clear that this is one of the millions of examples of the problem with healthcare that, again, not only is it rightfully yours, but if you're pushing back on it, what is it that you're trying to hide? When we do get the data, the answers are there. And you see why they're trying to hide them. Yeah.
And there are so many layers, Scott, right? So I think you hit the nail on the head. It's really hard for an employer to wrap around the fact that, the average tenure of a broker, according to Marshberry, that visited with us in our mastermind, was 6 years. And that's for a broker that is failing miserably at their job. Actually, it's agnostic. It's like, They could be crushing it, doing a really good job, which in the traditional broker world might mean 5% increases year over year. You're knocking it out of the park. Oh, 1 year we were flat. Woohoo! Right?
Yeah.
And then if you go to the broker that is consistently bringing back double-digit increases to their client year over year, which means that their rates are pretty much doubling in the 5 to 10 year mark, right? Double-digit increases compounded over time. It adds up pretty quick.
Yep.
Yet brokers are still keeping their job, and by and large, those traditional status quo brokers, their compensation is going up with every premium increase. So
Yep.
it's crazy how that works, but that is the way that it works in healthcare, folks. So you could be doing a terrible job, and you can be raking in the cash harder and harder year over year for doing the same or less work than you did before. And these brokers just continue to keep their clients, because I think it's the way that their clients have been conditioned, and it doesn't change much from one industry to the next, from one organization to the next. It's only when an employer realizes and the light bulb goes off that they say to themselves, well, this is one of our biggest P&L expenses. Typically, it's second only to payroll. Depends on, the industry, of course, but it's rarely, falls below a top 5 expense. It's a big expense.
Yeah.
And yet they have no mechanism or way to manage this expense. And it really just starts with understanding, I think, our conversation and who the players are. Yep. Because when you're in a fully insured plan, let's just use that as a baseline. So let's say that you're not in the know and you're not in a custom plan or a self-funded plan, but you're relying on the insurance carrier. Who are the insurance carriers? The other, the other term in our circles are the BUCAs, right? And so it's an acronym, lots of acronyms in insurance. So B for Blue Cross, U for United, C for Cigna /
Cigna, and then the A is Aetna. There used to be an H on the end of that sometimes, but
yes. So Cigna and then Aetna, but Aetna was bought by who? By CVS. So that's the other C that confuses me, right? Yeah. So it's a pharmaceutical company that bought an insurance carrier. And so if you think about it, like, that doesn't make any sense. You would think, of course, the insurance carrier is bigger than the pharmaceutical company. Nuh-uh, not in this case. In this case, the pharmaceutical company bought out the insurance carrier, and there used to be an H for Humana, but Humana is pretty much not in the same, not in the business in the same way. They're more in the Medicare space than they are in the traditional healthcare space. So these are the BUCAs. And the BUCAs are managing all of their affairs for the people who are their fiduciary concerns. And the people that are their fiduciary concerns are who, Scott? Shareholders, right? The people that buy stock in those companies. Because, and look, we've spoken many times before, and I think we're both entrepreneurial. We're both capitalists. There's nothing wrong with making a buck. There's nothing wrong with wanting to make more money.
No.
I don't subscribe to, the adage, money is the root of all evil and all this other nonsense. Bullshit. If you're in a for-profit business, or you're working for an employer that is a for-profit entity, and even the nonprofits, that's a conversation for another day.
Okay. Yeah.
But let's just focus on the for-profit entities. The whole idea and the objective is to show a return to your shareholders so that your business grows and everyone prospers. There's nothing wrong with that. Zero wrong with that. The trouble, though, that I have is we have healthcare, which is now $5 trillion in the U.S. It's a fifth of our GDP. Practically 20 cents of every dollar is spent on healthcare. And the driving force behind it are the BUCAs, the insurance carriers that are all publicly traded. Their pharmaceutical divisions, Optum is the biggest business operating unit of United Healthcare, which is the juggernaut. They're the giant, in the room. And everything that they do is for the benefit of their shareholders. Well, how could you have everything that you do be in the benefit of your shareholders and, purport to also serve your policyholders? You cannot do that. It's impossible.
It
And
is.
so I
Yep.
don't know what the answer to this question is, folks, but I could tell you that is an ass backwards, upside down model that needs to be changed, and the MLR needs to be repealed at the very least. You cannot have federal law, which the ACA is, and the MLR is baked into federal law, that says the more money your organization bills, the more money it makes in the way of profit. And that's exactly what the MLR does. So these insurance carriers are incentivized to do what, Scott?
Raise prices.
Bill more, because when you bill more, what happens? What happens to your shareholders? Are they happy or are they sad?
Yeah, right.
They're happy, right? They're very happy.
Yeah,
And
they've been
Yeah.
preying off an industry that's not transparent. So it's up until maybe a handful of years, right? Some of this stuff is still yet to be deciphered and understood by people. They've been preying off this non-transparent market that is unlike any other in the whole world, let alone in the United States. Healthcare is very different. I was on a call this morning with an organization that's owned by a German company. They can't even get their heads wrapped around it. It makes zero sense to them. It's very upsetting to them. There's no logic in place, etc. But yeah, it's completely backwards.
Yeah, well, it doesn't make sense to anyone that has a brain in their head and cares to take a look, because it's just patently bad.
Yeah,
It's a bad deal for the public.
Yeah, and they play on both sides of the fence. So I'll hear people say, well, I get what you're saying if I'm a fully insured group. But if I go and I self-fund, but I use UHC as my administrator, they're going to help me cut those costs, right? No, they're not. They're not. It's in the same family. If I cut the cost here through my PPO network,
Yeah.
let's say negotiate harder prices, that feeds over into my fully insured, which brings the premiums down, which cuts my margin.
Yeah.
So it's all in the same family. So if you're working with the BUCAs, you're getting non-transparent situation, whether you're self-funded or not. Even if you're self-funded, you're still only getting really half the picture when it comes to the data that they are willing to share with you. And given all that we've talked about, no, they're still on the wrong side of the fence for what
Yeah.
you do as
Everything is running on the same chassis with the BUCA. So for any employer or director of people or CFO or CEO, business owner that's listening, that says, "Oh, that's not us. We're self-funded." Well, okay, so congratulations, you're self-funded, but that's really just the payment mechanism. It just means that you're okay. You're not. You're maybe one step down the road to managing the expense, right? Certainly better off in most cases than being in a fully insured arrangement. Fully insured, you're kind of prepaying an expense. You're looking in the rearview mirror, and you're not doing anything to manage and control your expenses. Let's just be honest.
Yep.
Self-funded is, okay, a little bit better, but it's not simply enough to be self-funded, because as you said, Scott, if you're self-funded, which essentially means that you are now, as the employer, you're now the insurance carrier, essentially, right? You're
risk taker. Yep.
You're taking the insurance carrier out, and you're stepping in saying, this is our plan now. ABC Co., this is our insurance plan, and the buck stops with you. Okay, that's great. Good step in the right direction.
Yep.
But if now you say, well, I still want my members to have access to the BUCA network, and we're going to let them manage everything just as they would in a fully insured plan. Well, then are you any better or worse off than you were before? You could almost make an argument that you might even be a little worse off,
Yeah.
because now you're taking on additional responsibility that you otherwise wouldn't be taking on if you were in a fully insured plan. And I don't want to go too deep into the weeds
Right.
with that risk, but we both know that if you have the proper stop loss and safety nets in place, that the risk associated with a self-funded plan versus a fully insured plan is negligible at best. It's essentially, I would argue that a self-funded plan done right tilts the scales in your favor, and you're less risky than you are in a fully insured plan. And here's why I say that. I say that because when you're with one of the BUCAs, and if you pull out your medical insurance ID card right now and you see United, you see Blue Cross, you see Cigna, you see CVS, Aetna as the logo that's on your card, you're with a major insurance carrier. And to Scott's point, they are managing everything that's going on in your health plan for the benefit of their shareholders, not for you. And so as the employer or the CFO that's looking at this expense that they can't wrap their arms around, whether you're self-funded or not, if that logo is on your ID card, know with certainty that you are not in control of your costs. You are just not. There's no sugarcoating it. They are managing it. You're not managing it. And when you're in a role as Scott was, where you're adjudicating claims and you're looking at claims as they come in, and what does that mean? Well, at the end of the month, when you get your credit card bill, do you just pay it blindly, or do you go through it line by line? Well, in one of the BUCA camps, they auto adjudicate a good percentage of their claims. The majority of claims, in fact, are auto adjudicated. It happens automatically. And it's only kind of the exception that a claim will be flagged and they'll put eyes on it. And that leads to a lot of waste and abuse in the system. And what does that mean? It means that your plan is being overcharged. It means that those overcharges are going to lead to future rate increases. And it means that as an employee, that raise that you were looking for has just evaporated. That vacation that you were looking forward to is gone. And this is a predicament that is really eating away at the very fabric of our society. And it's bullshit. It's complete bullshit. So how do you break out of that? So if self-funding is the first step, and the second step is self-funding with active management, where now we're not just relying on the insurance carrier, the BUCA infrastructure to be kind of the foundation that the plan sits on. What are some other options for folks if they wanted to be self-funded but do it right? What does Valhalla look like? What does the Oasis look like? What does it look like over the rainbow? What if anything can be done? Or is this podcast just done right now? Are we finished?
Yeah, there's a lot. I mean, the key first is to look for independent organizations, right? You don't want to work with organizations that are owned by the BUCAs, let's say, so you have third-party administrators out there that go under different names like UMR or Meritain. UMR is a UHC owned TPA that they use for self-funded business, or you can do a direct administrative services only agreement with United Healthcare and have them do the administration. They have a couple different ones, but UMR is owned by them. Meritain is owned by Aetna. So even though you're with an independent, with a TPA like that, and you've moved self-funded, you're still in the family, right? You're still using the same networks. You still have the same constraints. You still have the same challenges, the inabilities to audit claims, all those types of things. So you need to find independent third-party administrators, number one. Those independent third-party administrators, if they're good, will have organizations like mine as partners to attack the major component of what your healthcare spend is today, which is your claims. Medical claims and pharmacy claims drive 85% of your cost, whether you're a fully insured group and from a premium perspective, or it's your self-funded and you've got your different components. I've got my administrative fees through my TPA, I've got claims fees, and I have my stop loss insurance. Claims still are the majority of your spend. So unless you have solutions in place within your health plan, which can only take place in the self-funded world where we're going, that mitigates the costs of those medical and pharmacy claims, you're still not going to get anywhere. So to your point, you can move self-funded, but if you're in that same family, you're going to have that same situation. So what you really need to do is look completely outside the box. There's nothing in healthcare that says you have to have a BUCA as a partner, number one. There's nothing in the healthcare rule book that says that you have to have a traditional PPO network, a preferred provider organization, a network that is owned and operated by organizations like the Blues. You don't need that. Under ERISA and under the controls that are given to an organization that do want to self-fund, you can piece together your plan the way you see fit, as long as, of course, it follows rules and regulations as set by ERISA, which means you can move forward without a PPO network. Use a pharmacy benefit manager that's not one of what you and I would call the big three, Optum, Express Scripts, and CVS, that still own about 80% of the market.
Yeah.
That 80%, that same thing on that pharmacy side is what we were talking about on the medical side. PBMs make more money when you spend more money.
Right.
They want you to, your membership to get as many prescriptions and fill as many high dollar drugs as possible. So you got to look at independent partners, and you got to look outside of the traditional model, because you and I talk about this a lot. It's not a broken system. That's what a lot of people say. It's clearly not a broken system. It's designed exactly how the big stakeholders wanted it to be designed. So it's breaking through that design and bringing people alternative solutions. And when you do, removing the PPO network and using things like reference-based pricing, or doing things where now that I don't have my PPO network and I'm not working with the BUCAs, I have the ability to do direct contracts with these providers, which, by the way, providers, health systems, when you do get the opportunity to talk with them, they don't want to work with BUCA either. They really don't. Yeah. They just don't know how to do it. How do I work with the guy across the street? He's got money, he's a self-funded employer, and I want him to come here. And, so you've got organizations like AMPS and others that are out there that can deliver solutions that are not the traditional setup, what we would call the status quo, right? And the result of those models is incredible savings. We're not talking about chasing the lowest increase every year, which seems to be, again, from a conditioning, employers are happy that I only got a 5% increase. Last year I had a 15. Now I only got 5. Well, that's still an increase, right? There are solutions out there that can bring you significant decreases. A lot of times, again, this goes back to the fear of change. That seems to be my biggest competitor, to be honest with you. It's employers that just can't get their heads wrapped around not having Blue Cross Blue Shield on my ID card.
Yeah, and there's a lot to unpack there, but I think for business leaders that are looking for a better way, if you listen to our conversation, it sounds an awful lot like there's a supply chain, right? Sure. Guess what? There's a supply chain in healthcare, right? So you need to understand that. I like to call it, just for lack of a better term, like when you're buying a fully insured plan, it's kind of like you're grabbing a box of cereal off the shelf. Everything is in the box, right? So everything that Scott is talking about, the pharmacy and managing claims and all of that stuff, these are all different components of your plan. The BUCAs make it really easy for you to just grab that box and go. But the reality is, if you want to wrap your head around how do I control the expense, you need to break apart that box. And it kind of calls to mind. I don't know if anyone's a fan of that show Billions, and there was one of the characters that grabbed like an iPhone and smashed it to smithereens to find out what the components were that were in that iPhone so that they could invest in it. This is the same thing, right? We're deconstructing it. We're taking it apart so that we can break it down into the sum of its parts. And when you understand that only 15 to 20% of your total bill is made up in administration, well, then that tells you that 80 to 85% of it is claims. And then you start breaking that down and you say, okay, pharma is going to be 20 to 30% of that claims bucket. And my big ticket items, the inpatient hospital stays, it's going to be another 30%, and so forth and so on. And then you find folks that are in this space that are not, they're not selling out. They're not the men and women that are working for that system that, to Scott's point, it's not broken for the bucas. It's working just fine for the bucas. It's not broken for the major pharmaceuticals. It's working just fine for them. And the PBMs really the middle. So not just to make the distinction, not necessarily the pharmaceutical manufacturers, in some cases, yes, but Correct. It's these pharmacy benefit managers, the Optums, the Express Scripts, the CVS Caremarks that are sitting in the middle and not even touching the drugs, but just profiteering and making money because that's the way their contracts are written. And so when you understand that you can break that apart, break apart your health plan, and then start understanding, well, how much can be optimized if I break this 20 to 30% of my claims bucket into pharma spend. How much, Scott? How much money do you think, like, what, without being like fantastical, what would you suppose the average savings in pharma alone would be if you moved from Express Scripts to Drexy?
Yeah, routinely, we're seeing a 40 to 50% drop.
Yeah.
So what a lot of people do in our industry is, in order to bring it down to a number that makes sense and can figure in the variables, like how many employees I had last year versus this year and things of that nature, to give you a benchmark on that, a Drexy case runs an average per member per month cost, and that includes your drug spend, and that includes the administrative costs. It's, let's say Drexy needs to charge, we need to make money, to your point, around $45 per member per month. Industry average, especially on the big three, who have, again, about 80% of the market, is about $120 per member per month. So the savings is significant. And again, you're working with an organization that's independent. It takes a co-fiduciary role. For any of the audience that's listening that is working with one of the bucas, that's a really good question to ask your buca. Would you be willing to take a co-fiduciary role within me and my self-funded plan?
What do you think the answer is going to be?
Yeah, I guarantee I know the answer to that question.
Yeah.
There's a few demand poll questions that we ask, or that we give to employers or consultants. That's one of them. Another one is on the medical side. Hey, Mr. Buca, from a PPO network perspective, don't tell me what your discounts are, right? Discounts mean nothing because the bill charge is a made-up number. But could you benchmark your discount back to a percentage of Medicare, which is a benchmark that people really understand, so I can get a real value of what your network is really giving me? Can you do that for me? They won't do that either. So yeah, it's a very interesting thing. But yeah, so when you put in a model that focuses 100% on the employer and its members and doing what's right for them and keeping it in a non-transparent model, you can reach those types of savings very easily, and on the medical side and on the pharmacy side. We just remove all the misaligned incentives. PBMs, according, the big 3-inch contracts, right? Have upwards of 70 plus ways to make money off of a single employee. 70,
Yeah.
0. So
70.
it's owning it. They own product, they dispense product, they prefer product, they keep rebates, they do things like spread pricing. I'll pay the pharmacy $10, but I'll bill you $40, and I'll put $30 in my pocket for doing nothing. If you take a PBM model, which is important, right? You got to administer these claims, and you break it down to a single per employee per month budgetable administrative fee, and you remove all those misaligned incentives, it's not very difficult to get down to that $44 per member per month versus the $120 per member per month.
Yeah.
I think people are conditioned that healthcare costs just go up. Yes,
Mhm.
Ray, I understand it. Claims are driving everything, but I can't do anything about claims.
Yeah.
That's the biggest misunderstood thing in this industry right there.
Yeah, 100%. Well, I think you hit the nail on the head earlier when you said your biggest competitor is fear of change, because I mean, that's brilliant, because it is true. And I think that, boils down to, it gets back to culture and the famous, Drucker quote, culture eats strategy for breakfast. And I laugh at that and I say, well, if you don't have strategy, you can't have culture, because you'll be out of business if you don't have strategy. So I get it though, right? So your culture should inform your strategy. But I think it's a huge miss on the part of leadership to think that doing anything that we're discussing today means that employees are somehow worse off, that they're not going to have the same access to care and treatment. And to be clear, if these strategies are not executed and communicated properly, there can be friction, there can be pain, there can be disruption. But I think the industry has come a long, long, long way. And I think when you're aligning with the right partners, that friction is at best short-lived, and realistically, it need not be a true concern, particularly when you're looking at the fact that we know that in healthcare, it's counterintuitive, but the highest quality is often the lowest cost. The lowest quality is often the highest cost. That has to do with efficiency and volume and a number of other factors. Yep. And so when you have a plan that's managed properly, instead of being in love and infatuated with the logo on your ID card, and none of the BUCAs, by the way, administer healthcare, right? They're not the physicians, they're not the facilities, they're insurance carriers. So they're not administering the care. And if you can have a direct contract relationship, and you can have a team like Scott's go into a local healthcare system and negotiate and say, we'd like our members to be able to access care at your facility. And by the way, when you work with us, one of the huge benefits for your hospital is that we're going to pay you a hell of a lot quicker than the insurance carriers are, and that's going to increase cash flow, and there are going to be some huge advantages for you there. I believe you have people on your team that are having those conversations every day. Is that not true?
Oh, yeah. Some of the biggest healthcare systems in the country and in certain states, I'll just rattle off a couple. Northwell, which is a huge health system out near you in New York. Advent down in Florida. Aurora Health is the largest health system in Wisconsin. We're working directly with all of them. We have direct contracts with all of them. They're below the reimbursement levels that they're getting from the BUCAs. So I always get that question. How in God's name are you getting a better discount off Aurora Health System's services than United Healthcare and their billions of lives? And it goes back again. We don't want to go down a rabbit hole again, but it goes back to some of those comments I made earlier about where these health systems really don't want to work with BUCA, and there's some challenges there in getting paid. So yeah, it's happening a lot. So there's a combination of doing certain reimbursement strategies along with the direct contracting, getting care navigation and steerage around it, giving information to members. That's one thing we've been trying to tell members for years: be a consumer in healthcare. Well, that's impossible, especially in a fully insured or some of these other types of models that we've been talking about. I don't have any information. I don't have insight into price. I don't have any tools. You get with independent organizations that are doing things differently, and that stuff exists.
Yeah.
And it's all about member education. My poster child for success is an organization I have in Indianapolis. Every year they do total compensation meetings with their employees. I pay you $40,000 a year, but you cost me $52,000. Well, why is that? Well, it's called payroll taxes. It's called I pay for part of your insurance or most of your insurance. You do. Employees that it falls out of some insurance money tree in the backyard or something.
Sure. Yeah, the hidden paycheck. Yeah.
Yeah. And when we started working with them years ago, they had about a $5,000 deductible, which is unfortunately a lot more common these days than people would think.
Yeah.
The deductible now is $700.
Wow.
The idea here is get control, make these moves, move self-funded, work with independent groups, look outside the box, find ways to control your costs, significantly drop your costs, but then share it with your employees. Lock arms with your employees. So now with that employer group, there's no way they're going anywhere. The employees get it. Some of the disruption that you mentioned before, they've gotten very comfortable with, and they see the value of it. Oh my gosh, look at what's still in my paycheck, which wasn't in my paycheck in the past.
Yeah.
Now I know why my employer did this, and they're loving it. So when we get the opportunity to work with employers that grab a hold of this and really control it, don't want to look at their healthcare cost twice a year or once a year, 2 months before you renew it. Healthcare is a marathon, not a sprint. This isn't about a strategy you look at every year. You want to look at a strategy of how you can affect it in the long term. It's successful and it works.
Yeah, no doubt. And there's a lot to be gained from working with organizations like yours. And the one that I would argue is worth the price of admission is transparency, knowing exactly where your money is being spent and being able to put eyes on that expense and managing it, figuring out, is there something we could do here? I have a high claimant. I have someone that's, taking Humira and they have an autoimmune disease and it's $100,000 bill a year drug. Is there something that can be done? At least you have the opportunity. Maybe, you don't think you'd be successful. Scott and I know that, we can dramatically reduce the cost of a drug like that. There are ways where that patient may be eligible for that drug for free through federal assistance, and it might be available to an employee that you would think otherwise would not qualify because they make too much money. Well, the reality is these programs, these drugs are so costly that you'd be amazed that some people can earn into the six figures and qualify for some of these extraordinarily high-priced drugs, and have a drug like that's free to the plan and free to the member. It's a win-win. So look, we could go on for days, Scott, about this stuff. I think the takeaway for employers is this is a manageable expense. Believe it or not, we do it every day. Your organization, AMPS, what are you, 6 months in now? How you're a brand new startup company, right?
No, it's been around almost 20 years at this point.
Almost 20 years. 20 years doing this sort of thing. You've made some acquisitions. Tell us just a little bit about the makeup of the organization. What does your organization look like?
Yeah, I mean, at the end of the day, the term I like to use is it's cost management, claims cost management on the medical and the pharmacy side. So through our Drexy organization, which is an acquisition we made about 4 years ago, really added some functionality and things to it. It's a full service pharmacy benefit manager.
Hmm.
We can help save a ton of money on the pharmacy side. On the medical side, we've got a couple different options. What AMP started with about 20 years ago is what we would call physician-led medical bill review. So that's looking at the time, high dollar medical claims, some of these surgeries and other things that you mentioned earlier that, can be huge dollars. Years ago, $1 million claim used to just stop the shop. Now they're a dime a dozen. But the idea was, let's look at the claim from the provider and make sure that it was billed accurately. What a lot of people don't understand is the complexity of that, the errors that can be on a bill, uh, as true errors or purposeful errors to drive up the cost. Um, in doing that specific product, looking at claims for 20 years, this is a pretty scary statistic. 91% of every single facility-based claim that we look at is riddled with errors. 91%. And that's about, on average, an 8 to 10% of the bill charge. You get a $100,000 bill from a hospital, there's a 91% chance that upwards of $10,000 have no business even being on that claim for all
Wow.
kinds of reasons.
Yeah.
So we started doing that about 20 years ago. It's still a product. I sell that a lot in the Medicaid space, helping them control their risk directly with health plans that are taking their own risk and are trying to find ways to keep those costs down. And then we also do it in the out of network space where there's no PPO involved. Let's look at that claim, let's get the errors off of it, but then let's look at what are some reasonable reimbursements for some of the ridiculous charges that we see. $500 for a Tylenol. That's not one example over 20 years. We see those.
That's reasonable.
Yeah, right. $1,000. This was in the news years ago for AMPS. It went from a local newspaper to actually on the I think it was on the national news. The $1,000 toothbrush that was built by a hospital. And if you've ever been in
Crazy.
a hospital, folks, and unfortunate for an inpatient stay, and you get one of those toothbrushes, it's actually like a half a toothbrush. It's not even a full plastic toothbrush. It's like a little mini
Not gold plated.
$1,000. So we audit claims. We do what we call reference-based pricing, which is a PPO replacement model, and using a different reimbursement strategy to pay providers and also do direct contracts. And then we have the Drexy. So when you roll it all together, we offer the ability for people to, utilize. You don't have to use all the services at the same time. They're not bundled together. Most of my clients do that because of the value, but you don't have to. But
And if you're a larger employer and you've been self-funded for years and you suspect that maybe you've been overcharged and paid, is there any way to go back and look retrospectively at years gone by? And I don't know, is there a waiting period or statute of limitations before you can go and collect those dollars?
No, and actually, that's a really good question. Yes, the best way to utilize a function like our medical bill review is to do it before the money gets spent, right? During
Right.
the adjudication process. We don't have time today, but there's a lot of challenges for that a lot of times. But yes, we have what we call a retrospective review and recovery product. We can go back 3 years. So we would get medical. This is on the medical side, so not the pharmacy side. We could go back 3 years, work with an organization and their consultant to get the data that we need, their medical claims for the last 3 years. I also need a few other things like a copy of the summary plan description and a copy of their current administrative services only contract and a couple things like that. But what we're going to do is re-adjudicate all of those claims, taking all that information and then looking at, as a result of that, did that organization overpay? And if they did, to what providers did they overpay? Then we roll up our sleeves, contact those providers, and recover as much of that money back as we possibly can. It's very successful. Unfortunately, we talked a little bit about the CAA earlier.
Yeah.
The CAA, part of those regulations say that if a self-funded entity requests their financial claims data, and they'll call out a couple actual data elements of what they're referring to, like the allowed rate and the billed charge and the CPT codes, which are procedure codes that providers bill, those kinds of things.
Yep.
Then that is their data. It's rightfully their data. And therefore, that self-funded entity could give me those 3 years of data and I could do that work for them. It's amazing the things that we find. On average, we're recovering anywhere from 3 to 15% of what that organization paid across those 3 years.
Wow. That's
It's
crazy.
significant.
And so
Yeah.
for any size employer, it's going to be meaningful to the organization, right? It's kind of size agnostic, but for large employers, and there are plenty of employers out there that are spending into the 9-10 figures and beyond.
Oh yeah.
To be able to have an audit process like that take place, it's almost like a forensic audit is what you're doing.
Totally.
And go out there and recover those dollars. I would imagine you charge a fee of against whatever you recover. Is there a fee for an employer, like an upfront fee, or is it based strictly on what you recover?
There is an upfront fee. We call it our pair report fee. So payment accuracy, integrity, and risk is the pair report.
Mm-hmm.
So what we do is there's an upfront fee based upon the size of the group, the complexity of the claims, those types of things. Because for the first maybe 90 to 120 days of having this data, there's a lot of work to be involved. We have to normalize the data. We have to ingest it into our system. We have to re-adjudicate all those claims. We have to present some reports. Some of the claims kick out to medical directors and nurses and certified coders and stuff. There's certain things that systems can't do, right? We need some experts on them. So you got about a 90 to 120 days of let's run the data and see what we get. So that's our pair report. Valuable on its own. This is, we bucket it into different areas of this is where you have some issues with your claims administration, where you've got some leakage that resulted in overpayments. You got some issues here, et cetera. 99.9% of the time after we deliver the pair report and we explain, here's what we found and here's the problems that are going on, which is great information to bring back to your administrator. Let's plug these holes on a go forward so I don't continue to overpay. 99.9% of the time, the group then also wants us to move forward and try to recover as much of that money as possible. So what we'll do is the first X number of dollars of that recovery that equates to your upfront pair report fee, you get back 100%. And then every dollar after that we recover, we retain a piece of it for our revenue for doing the job. Okay?
Got it.
So at the end of the day, it's a guaranteed ROI. We will put in a contract that will guarantee that we'll recover at least, if not more, of your pair report fee. But we never miss that. That is negligible compared to that 3 to 15%.
So it sounds to me like the pair report fee is really just to make sure that you're weeding out the tire kickers, that the client is going to put some skin in the game.
You got it. That we got years ago. We tried doing it completely on the come, 100% contingency.
Yeah.
A couple people bailed out. Here you go with the issues with our industry. One of them was a very large employer. And then when the CEO found out what CFO was trying to do, he said, wait a minute, I sit on the board of these two hospital systems in our market. So we're not going to do this. Now, from a fiduciary responsibility and liability perspective, I hope that guy didn't share that with too many people because he would be on the chopping block. But we've run into that before. So that's part of the reason why we did it. But yes, it's highly successful. We work with organizations like AutoZone. University of Texas has about 200,000 members across the university. And we're about this close to finalizing the contract with Amazon.
Oh, wow.
By the way, is about $15 billion a year or something like that in paid medical.
Is that all?
How big that organization is. But when we ran across Amazon, it was interesting to hear their response of, wow, your timing is impeccable because we've been talking about this.
Huh.
The CAA and these regulations and the gag clause attestations that employers have to do every year, I think has really woke people up,
Yeah.
has realized I absolutely have to get my arms around this. I
Yeah.
have to get my hands dirty. I can't shuttle this off to a buka and a consultant every year and look at it for 30 days and be able to check that box that I'm doing what I'm supposed to be doing. There's a lot of
Right.
liability here. The Johnson & Johnson lawsuit is a big thing in this industry right now. That's where an actual member of Johnson & Johnson sued their own health plan for lack of fiduciary responsibility.
Yeah.
It'll be interesting to see where that goes. But going back to what you were saying before about this was big and always has been in the welfare space, right? In the retirement, 401k, and all that arena. But the spend on that side is negligible compared to the healthcare side. So
Right.
employers better start realizing when it comes to their consultants and people that they've partnered with. I know there's relationships, but you need to take a trust but verify approach with your health plan and your consultant like you do everything else within your organization, and get to that point of making sure you're aligned with the right people. It's the right thing to do.
100%. Hey, Scott, we could go on for days, but definitely appreciate you being a guest on
Sure.
Broken Healthcare Podcast.
Sure.
If folks want to reach you or reach out to you, what's the best way to get a hold of you?
Yeah, either phone or email. I'm on the website at amps.com. You can find me there and find a way to connect with me there. Would probably be the easiest, or I'm on LinkedIn as well.
So that's amps.com.
Yep.
Amps.com.
Yep. And that'll take you to Amps and Drexy. It's all under the same name.
Awesome. Yeah. So look out for Scott. He is obviously a guy who knows his stuff. For those of you who still think that you can't do anything about the cost of healthcare, if you're an employer, I'm sorry to say, but you're sadly mistaken. There's a ton that you can do. Partnering with a broker that is not a status quo broker, but a broker that is a performance-based broker that's going to put their money where their mouth is, look out for the best interest of your organization. And maybe instead of having bonuses paid by insurance carriers, which we would say is a misaligned incentive, think about rewarding your brokers based on their performance. That is, if they can get your cost to actually decrease and then eventually flatten out, which is possible with the assistance of folks like Scott and organizations like AMPS and Drexy and so many others in the space that are like-minded and aligned in this mission of ours to reduce the cost of healthcare for organizations, leadership, and all stakeholders. So Scott, again, thank you for joining us today. We look forward to having you back one day in the future, and keep up the great work out there.
Yeah, I appreciate it. You too, Ray. It's always great to meet with you.
All right, folks. Have a great one. Peace.
Yep.
Take
You
care.
too. We'll see you later. Thanks, Ray.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show. One lucky listener every single week who posts a review on iTunes will win a chance in the grand prize drawing to win a $15,000 value private VIP day with Ray Kober himself. Be sure to head on over to brokenhealthcarepodcast.com and pick up a free copy of Ray's gift and join us on the next episode.